Hi, good morning. I am Dr. Bhupendra Shah, Fellow Clinical Neurology, Department of Neuroscience, Grand International Hospital, Kathmandu, Nepal. Today, we will discuss about the approach to a child with hypotonia. In the neurologic clinic, often as a neurologist, we see a child with hypotonia and we have to evaluate the child. So, what we are going to discuss today? So, we'll discuss briefly about the etiologies of the hypotonic child, uh, and we'll also discuss how we are supposed to elicit the history and how we are supposed to examine the hypotonic child, and how we are supposed to narrow the hypothesis, and how to investigate the hypotonic child. So before going to the topic proper, that is the approaching the hypotonic child, uh, we should keep in your mind the common etiology of the hypotonia in the child. The the common etiology started from the central nervous system, and the common etiology that cause the hypotonia in the child are the chromosomal disorder like the Prader-Willi syndrome. Similarly, other chromosomal disorder like Down syndrome, Edwards syndrome, Patau syndrome, this can cause the hypotonia in the child. And there are different metabolic disease that can cause the uh, hypotonia in the child, especially the inborn error of metabolism. Okay, this can cause the hypotonia. Similarly, the cerebral dysgenesis can cause the hypotonia, and one of the common cause of hypotonia in our part of the old is hypoxic ischemic encephalopathy. So these are the cause of the hypotonia in child. Regarding the anterior horn cell disease, uh, the spinal muscle atrophy is one of the common conditions that can cause hypotonia in the child. And going to the peripheral nerves, the one hereditary peripheral neuropathy, that is congenital hypomyelitic neuropathy. Uh, these are the quite rare cause for the hypotonia in the child. And for the neuromuscular junctions, the child can be suffering from the congenital myasthenia gravis and the infantile botulism. Um, and in the muscle disorders, there are different muscle disorders like muscular dystrophy and the metabolic myopathies, then the other congenital myopathies that can cause the hypotonia in the child. So when you look at the etiology of the hypotonia in the child, the etiologies are extensive, and sometimes it is so confusing to uh, to the physician or the neurologist to approach such a child. Uh, but so we have to make a certain approach to for the diagnosis of the patient with hypotonia. So let us look at the evidence. So this is the one of the research done in Iran, uh, where they have seen the etiology of the hypotonia in the neonate. In this etiology, uh, the the central cause of hypotonia occur in around 79.66%, mean that when you see a child with hypotonia, most of the time the cause is of the central cause, and the central cause the cause is hypoxic is ischemic encephalopathy, intracranial bleed, or other CNS abnormalities, certain chromosomal disorders, metabolic disease like that. And around 20% of the child has the peripheral hypotonia, and the cause are the spinal muscle atrophy and the myopathies like that. uh, okay, so looking at the evidence, you can presume that the common cause for the hypotonia in the child is the central cause. So regarding the history, when you see your patient with hypotonia in our day-to-day clinical care, we have to take the history properly, because history gives us so many clues towards the diagnosis. Like in the family history, we should always ask history regarding the consanguineous marriage, because there are so many genetic disease that can cause the hypotonia, and like and that get revealed if the parent had the consanguineous marriage. Definitely, we need to ask the history regarding the health of other children in the families, and the genetic disease, like is there any premature death, or is there any anyone suffering from the similar conditions in the family or not, we have to ask to the parents. Regarding the pregnancy history of the mother, we have to ask regarding the maternal age, because the advanced maternal age is always a risk factor for the chromosomal disorders like Down syndrome. And we have to also ask history regarding the congenital infections like TORCH, because this sort of infection can cause the hypotonia in the child. And we should never forget regarding this drug exposure to the mother, because it can cause the teratogenicity in the child, and that can cause the hypotonia in the child. Regarding the birth history, as we see, one of the cause of the hypotonia in the child is the SI. Definitely, we need to ask the birth complications, whether there is a prolonged labor or not, whether there is a preterm rupture of the membrane or not, whether the child is delivered prematurely or not. And we should always ask the history regarding the seizure, because it can gives us clue towards the central cause. And then after the child born, we have to ask the history regarding the milestone development. The hypotonia in the hypotonic child have the delay in the motor development, but not in the social and the language development. If the hypotonic child has that problem even in the social and the language development, if the patient do not give the social smile, or if the parent children can't speak, then most of the time the cause is the central one. So it gives us clues towards the central cause for the hypotonia. Similarly, the feeding problems, because like there are so many disease that can cause the feeding problems, like if someone has the child has the myopathies, then child has problem in swallowing. If the child has the congenital myasthenia gravis, then the child get fatigue while feeding. So these are the things we need to ask to the mothers. And we should also note about the crying episodes. Abnormal high pitched crying usually suggests the central cause, whereas the weak cry suggests the peripheral cause, and the fatigable cry suggests the neuromuscular junction disorders. Similarly, we should also ask regarding the history of breathing problems, because if someone has the myopathies or the neuromuscular junction disorders, then the child can have the breathing problem as well. So when you get any patient with the hypotonia in our day-to-day clinical practice, we have to take the history very, very carefully, because history can gives us so many clues towards the diagnosis and to narrow our hypothesis. Regarding the general physical examinations, we have to always take note the dysmorphic features, like dysmorphic features. Like you can see in the first picture, where the first picture is a child suffering from the Down syndrome, who has the small head, microcephaly, and abnormal ear, than the typical Mongolian faces, small eyes. So these are the dysmorphic features, and when you are evaluating or examining the patient, we have to take care about the dysmorphic features. The second picture is a child with the Prader-Willi syndrome, where you see a obvious child and looking happy child. Okay, and not only the face we are supposed to note, we have to also take care of the different skeletal abnormalities, like whether there is the bilateral hip dislocation or not, whether there is a flat foot or not, because this gives a clue towards the different myopathies and the different muscular disorders. Similarly, we have to also take care of the cardiovascular abnormalities, because one cardiovascular abnormality is the cardiomegaly, so which is quite common in a child who is suffering from the inborn error of metabolism. Typically in Pompe's disease, there can be the cardiomegaly. So if there is a cardiomegaly, then that gives us clues towards the different inborn error of metabolism, as well as towards the myopathies. Yeah. Definitely organomegaly. Sometimes we have to also palpate the liver and spleen properly, because if there is a hepatosplenomegaly, then usually it suggests towards the glycogen storage disorder and lysosomal storage disorder. And similarly, we have to also take care of the skeletal abnormalities. So after doing the general physical examination, we have to do the neurological examination proper. The cranial nerves, the important thing that we have to take care of is that we need to check the eyelid, because if there's a presence of the ptosis, then it usually suggests the myopathy and the congenital myasthenia gravis. If there is extraocular movement problem, then it usually suggests the uh, congenital myasthenia gravis. Okay, and we have to take care of the bulk, because if there is atrophy, if we see the atrophy in the limbs, then it usually suggests the lower motor neuron lesion, starting from the spinal muscle atrophy to the myopathies. There can be the atrophy, and usually the muscle bulk is preserved in a central cause of the hypotonia. Regarding the tone, usually as we are looking after the hypotonic child, when the child is kept in the supine position, as in the picture you can see, the child takes the frog leg position, where the hip is abducted and knee is flexed. And when we hang the child, then child take the U-shaped position. Okay, so when you keep the child in the supine and the prone position, definitely we can get a clue towards the hypotonia by noting the position of the child. Similarly, usually the power is decreased in a child who has the lower motor neural lesion. Usually, in a child who has central causes for the hypotonia, the power is usually maintained. So we have to always differentiate whether child is hypotonia only or hypotonia with weakness. Hypotonia with weakness is usually suggestive of the lower motor neural lesion. Regarding the reflex, it's one of the important neurological examination that we are supposed to assess, because the Briggs reflex, exaggerated reflex, usually suggests the central cause, whereas the reduced reflex or hyperactive reflex or absent reflex usually suggests the lower motor neuron type of lesion. Okay. Similarly, the primitive reflex like Moro's reflex, rooting reflex, uh, shocking reflex, and the palmar grabs, these are the reflex that can persist for the prolonged time if the patient has the central cause of the hypotonia. If the child has the, like, let's suppose hypoxic ischemic encephalopathy, then the Moro's reflex can persist even after 3 to 4 months, because the persistence of the primitive reflex usually suggests the central cause. Similarly, the postural reflex like writing reflex, parachute reflex, these are the reflex that can go in a child with the peripheral cause. If someone has the peripheral cause of hypotonia, like spinal muscle atrophy or peripheral neuropathies or myasthenia gravis, then the child, because of the weakness, the child cannot have so the postural reflex. And another important point that we need to note is the spontaneous abnormal movement, because if there is a presence of the fasciculation, especially in the tongue region or in the muscles, then it usually suggests the spinal muscle atrophy. Okay, spinal muscle atrophy. But not only examining the child is important. Sometimes, if you examine the mother or father, then sometimes it may help you to diagnose the condition. Like in case of congenital myotonic dystrophy, if you examine the mother properly, then even the mother can show the feature of myotonia. Similarly, if you examine the mother in a condition where there is a congenital myasthenia in a child, then mother might show the feature of the myasthenia gravis like ptosis. Okay. Then the so we have discussed regarding the different etiologies of the central hypotonia, and how we are supposed to elicit, and what are the important thing to examine if we get a child with the central hypotonia. But definitely we need to differentiate the central hypotonia from the peripheral hypotonia, because this will guide us towards the further investigation. So if the child has a sign of abnormal consciousness like poor GCS, low Abgari scores, then the most of the time the cause is the central cause. If the child had the feature of the seizure, feeding difficulties, axial muscle weakness, and the exaggerated reflex, then usually the cause is the central cause, and usually the cause is in the brain. Regarding the peripheral hypotonia, if there is a postural reflex is absent, and the child does not have any feature of the central environment like seizure, abnormal consciousness, then we need to think about the peripheral hypotonia. Definitely, the peripheral hypotonia, anterior horn disease is usually is the in the anterior horn there is fasciculations, absent reflex, proximal muscle involvement in anterior horn disease, especially in SME. Child can have breathing problem, child can have the swallowing problem in anterior horn disease. In case of peripheral neuropathies, it can show the feature of peripheral neuropathies, like the child can have the symmetrical or asymmetrical uh, uh, decrease in muscle bulk, hypotonia. And similarly, the neuromuscular junction is shown by the fatigable weakness, and the myopathies, child can have the usually the proximal muscle weakness with no sensory symptoms in the case of the myopathies. So we can differentiate the one by one. So regarding the investigation, after taking the history and examination properly, and after differentiating whether it is a central hypotonia or the peripheral hypotonia, if we think it's a case of central hypotonia, then we need to do the neuroimaging, preferably MRI is better, because it can show the different cause of the central hypotonia. Like MRI can give us the evidence of the hypoischemic encephalopathy or any other structural abnormalities or brain hemorrhage, like that. Okay, if you do the MRI. If the MRI is normal, and if you still thinking the cause is central, then we need to do the genetic studies, especially the karyotyping, which help us to diagnose the different chromosomal disorders like Down's, Patau, Edward, and the Prader-Willi syndrome. Similarly, if we are thinking of the spinal muscle atrophy, then we have to do the SMA gene analysis. And if you are thinking of myotonic dystrophy, then we have to look for the trinucleotide repeats. Okay. Definitely, before doing these all hi-fi investigations, we have to stick with the basic, and we have to send the CK total. If there's a very high CK total, then it usually suggests the myopathies. And one of the important reversal cause of the hypotonia in the child is the hypothyroidism. That's why we need to send the thyroid profile to each and every child who has hypotonia. And definitely we have to look for the electrolytes, especially calcium, because the calcium disorder can cause the hypotonia in the child. Regarding the lumbar puncture, yes, definitely some encephalitis can present as hypotonia, but if the history is suggestive of encephalitis only, then only we are supposed to do the lumbar puncture. Otherwise, we can defer these investigations. And another important test that we can perform is the screening for inborn error of metabolism. The clue for screening for inborn error of metabolism is child is absolutely normal in day 1 of the birth, but after day 2nd and day 3rd, if the child becomes hypotonic, then we have to send for the inborn error of metabolism, and for which you can say the test like tandem assay spectroscopy and urine for reducing sugar, like that. And then definitely if you are thinking of the different neuropathies and the myopathies or anti-onset disease, electrological physiological, especially EMG, can help us in that scenario. So these are the different tests, but there are so many tests, but which test we have to perform and which tests should come earlier, that should be guided by the history and the clinical examination. Muscle biopsy usually not required, but only in case of muscular dystrophy, it is required. So the take-home message from the today's presentation is, if you see any child with hypotonia in our day-to-day clinical practice, there are extensive differential diagnosis ranging from very benign condition to the fatal conditions. But we need not to worry, because we have to develop some systemic approach, like taking history properly, examining the child, and differentiating from the central from the peripheral hypotonia, and investigating and accordingly. And so when we, after making the hypothesis should drive the investigation that we are going to perform in the child. Otherwise, we will be confused and we will never reach towards the diagnosis. Because if you narrow the hypothesis from history and examination, if you investigate properly, then we can reach the diagnosis in the proper time, in a cost-effective manner. Thank you for your kind attention. If you have any queries, you can write in the comment section.